So I'm Ron Pies, and I am editor-in-chief emeritus of Psychiatric Times 2007 to 2010. I'm also a professor emeritus of psychiatry at SUNY Upstate Medical University, and I have a similar position with Tufts University. Well, when I first started, which was, I think, the Paleolithic era, I was trained in residency in the late 70s and 80s when we were largely using tricyclic antidepressants. The more adventurous among us were using monoamine oxidase inhibitors, and that's pretty much all we had. The so-called SSRIs, which are not necessarily all that selective, didn't really become available until the 80s. And most of my career after residency was spent with these early SSRI agents, later the SNRIs. And it's really only in recent years that we have a variant agents like vortioxetine, one of the ones that Dr. McIntyre has done some very important research on, that seem to have a better side effect profile in many respects than the classic SSRIs. Um, so the treatment of depression has changed. I wouldn't say that we have tremendously robust antidepressants that work for everybody, but we do have antidepressants that are effective and whose side effects can be successfully managed. And then, of course, we have newer approaches to depression, major depression, like esketamine and other somatic treatments. So the field has changed. It hasn't been a revolution in antidepressant treatment, but there has been some, shall I say, evolution. I think I'd want them to remember that depression is an umbrella term that really doesn't tell you very much. It's kind of like saying that your car has engine trouble, and you go to the mechanic, and the mechanic says, "Yeah, your car has engine trouble." It really doesn't tell you very much. I think whenever we see a patient with depression, the first thing is really to think about differential diagnosis. Is this a depression that's fueled largely by, quote, organic medical factors, ruling out things like hypothyroidism, for example? How much is it driven by characterological features? Um, how much does it conform to the DSM criteria, which, by the way, are very, very broad for a major depressive episode? And as our colleague Dr. Gami has pointed out many times, um, it's not a terribly valid set of criteria. So differential diagnosis is very important. Uh, Obviously, there are, immediate emergent issues whenever we see a patient with depression, such as, is the patient in need of hospitalization? Does the person have suicidal ideation? Is there a psychotic component to the depression? Is it a melancholic depression? All of these have immediate treatment implications. And I might add, does substance abuse contribute to the depression? So we can't settle for just an engine trouble kind of view of major depressive disorder. It really is a very heterogeneous condition.